the C1 sinus. Yeah? Okay. It's called C1 drill out, but actually no drills are involved. That's why they call it drill out. They call it drill out because they want to compare together with the draft tree, right? Because draft tree is a drill out, but this is not a drill out. And there are no problems with it when it's the nose once you open up the C1 like that. Because there's not much bone exposed to the nose. Let me show you. So this is yesterday's specimen, and you like to recognize the structures again. So this is the section. And yesterday the demonstration was very good because the excellent anterior spectacally window has been done. This is anterior, and of course our nasal septal flap was partially gone. Then we have got the middle turbinate, and very nicely you can see that there is this spectacally is done. Looking up here, this is where, so this is the nice picture for you to remember. So before drilling, all this is gold. But when you drill upwards, you can see that, oh, this is the frontal sinus, which we all know from yesterday is very small. Here we have, of course, you know, Brent says something very important. If you open the maxillary sinus peak, use this level, you will know where the lamina capriccia is. So you can keep safe and you always keep medially. And as we go to the back, this is already an opening for the sphenoidotomy. You will notice that there is still bone here, right? So this is the anterior space of the sphenoid wall. Yeah? And when we approach the sphenoid from transnasally, you go from the middle turbinate, you go down here, and the superior turbinate has been partially cut, so they can see very clearly. So here we are. Now, the next thing, notice this. This is the middle turbinate, this is a superior turbinate. So all the stuff here is called a superior meatus, which is actually the posterior ethmoid. So the posterior ethmoid is actually the superior meatus, and the anterior ethmoid is the middle meatus. Yeah? And you all know where's the inferior meatus, right? The inferior meatus is down here. And what's so nice about the inferior meatus? Two things. One, this is the pathway for antral washout. So many of you would not have seen an antral washout. I got a nice video, and you can tell your boss to invite me so I can show you the video. And of course, further up there, okay, I won't take up too much time here. So the other interesting feature would be the opening of the nasal rectal duct, right around from here. Yeah. You just press on the right. So, yeah. So it doesn't work because after all this is the air, yeah. Okay. So it is actually quite anterior. So when we make a hole, sometimes we make a hole through here, in order to put the. I'll show it to you. To put the debrider in there to get a polyp. You can get difficult polyps from here, yeah. And you won't injure the nasal rectal duct. So, I think there's one trick I want to teach you. Supposing now we look into the sinus, and you see that there's a polyp there. And this polyp is in the floor, in the curve. And we are trying to take it out. We have a few risers here. So, you will find that you make an opening like this, and then you can't get the polyp. The polyp is beyond your reach. Or there are multiple polyps. And you want to carry a bit just to reduce the polyp load, then you don't have to worry about this. We can go in the inferior meatus. Let's go to the inferior meatus. So this one is this is a very useful trick. So here you lift this up, then we see how to get in there. So I just push this away, and then I will make a cut here. In real life, you just give an injection and then cut here. Okay, cut here, and well, this guy is very thin. But let's make a cut here. Don't have to be very big cut. And let's take my favorite instrument, the chisel. So heating, and you come here the chisel, and then later give me a straight divider. Just chisel it. Cut. Mostly, man. Chisel. Don't worry, it's just So it's like a small hole here. Can I have a divider? Well, since the divider is not here, can you imagine that therefore you will take this, do some imagination, guys? You take this and you poke it through. So now, supposing this was the divider, right? This was the divider. You can divide everything here, yeah? You divide all the polyps and you put if you put the angle scope. So I'm putting a 70-degree scope. So this is a very neat trick, yeah? So you can catch all the points you want, yeah? But it doesn't go, the divider, you just want to show this. Here as well, yeah? So that's the bone, don't worry about it, so you can divide everything here. So because the demonstration, the bone just wants it away. See, you can get every part of the sinuses, yeah? Polyps. So it's much easier to do this, yeah? So this was a neat trick, yes?
You don't make incision from the mucosa?
Just a small incision, more than enough. Very small incision, because everything is going to heal. Good thing I knew this trick, because when I was in Kuwait, there was a Kuwaiti doctor who purposely sat behind me. He was going to go back to another thing, but he said that I want to see how you take out the polyps from the floor of the nose, yeah? So good thing I knew this trick. Otherwise they wouldn't pay me, yeah? So now, okay, this scope is a bit different to use. So let me try inside. Here. So you can see your divider, you can chuck, take out everything, yeah? Almost everything from here, yeah? And you'll melt away like cheese, yeah? After which you take it out and let's have a look at the hole. What are we going to do with it? You don't have to do anything, yeah? Thank you. Yeah, thank you. There's a positive demonstration for your divider. And then here, there's an opening here. You can leave it alone, don't worry. Yeah? Of course, the very sharp ones will tell you that maybe say, Prof, how about the recirculation? How about if mucus comes from here, goes into here, goes through here, and goes into here? Yeah? It's possible you cut the infiltrator lane. Yeah? But you don't cut infiltrator lane, it is quite impossible for you to do that. Yeah? Okay, hopefully not. So now we're going to go back to the sphenoid, yeah? Sphenoid phase. So it starts with, it's not a don't be so scared of the word. Okay. Whenever we open the sphenoid, we want to be sure that we preserve this artery, sphenoparietal artery, because it will bleed a lot. Actually, this is the evolution of facts. In the evolution of facts, before we did all this and understood the anatomy, we will go in there and then we will open here a small hole, and we will be very scared of the skull base at the top. So we will just cut below. To cut below, we will hit the artery and we'll take a bipolar and bipolar. That's what we used to do. Now we never do it. Yeah? Now we know better. So here, that's why that day, yesterday, Prof. Seti, he did this, right? He pushes all the way down. That's what we do. And in order to do a sphenoidotomy, we can do what we call a posterior septal window. Yeah? Give me a stick, please. So usually I just take a plate. Yeah? Or sit on that. Sit on that. Yeah? Okay, so here we are. We have the silicone line. So where do we cut? We cut horizontally. We cut horizontally because we know that the artery is coming up here, then it goes to branches. So this part, even if we want to use a flag, this is not involved in the flag. This would be the pedicle of the flag. The pedicle of the flag is here. Yeah? So you cut through here, and we can do everything on one side of the nose first. Yeah? So in real life, what I do when we are doing P3 is a special trick of mine. They always complain of a loss of smell. So we know all the smell fibers are coming down from here. You can see the smell fibers. There you are. I'm just kidding you. Okay. Anyway, no. The smell fibers are here and on the superior domain. So what we do is we will give a scissors. So I actually preserve this flat for the smell fibers. Flat, all right. Go to right into the keel. Thank you. And so we will push this up. Yeah, push this up. Of course, in real life, sometimes you will encounter the posterior septum now. The bone of the posterior septum is actually very thin, so it's quite easy to do this. So you push all these up. See what that? See that? Correct. Okay. So you don't need to free this area. Whenever you operate, everything in the center is safe. All the dangerous things are inside. So that's free this off. So this is all the small fibers. I push it up, yeah. And when you push it up nicely, it won't affect the surgery even though yeah. That's for when I'm operating with the neurosurgeon. And you can also go to the other side in real life. And in fact, in real life, you will see the sinus osteum there. So now you will see the anterior keel of the sphenoid. So everything is very safe here. And you push this away, push this down, so you expose more and more of the abdomen area. You will see more and more of the anterior keel, and you can feel this way. Sometimes there's a bit of bleeding. I take a piece of cotton, and I put it here and I use it to push it out. You push it out all the way here, and you see the mucosa on the other side. And you can hold only one side. Yeah. So push away, yeah. So push away. Of course, in real life, you want to be needed in this. Yeah. So we can approach this and make a very big opening. Of course, you can come to this side a little bit. Yeah. Bring it down. Bring it out. Yeah. So just to save time that I'm doing this, but you can do everything from one side. Bring it on here now. Alright? Okay. So you know the artery is safe here, on the flap, yeah, it's safe here. And now we can open this, but I prefer to take the kerrison. We take a kerrison and we try to detach this part of the skull base first before we chisel that. Here. So we detach it, So I know there's a central septum. Brute force. So there's still a central septum. Oh, so I detach it a little bit, yeah? Detach a bit, alright? Easy enough. Then my table has a begin. So here we go. So here we have we can actually just see how far you want to go, yeah? How big you want. If you put too big a piece of bone, it's difficult for you to come out through the nose, yeah? Okay. First crack. So that's a nice piece, so we take it up first. This is so this cadaver bone is quite brittle. Yeah. When we do pituitary, older people sometimes the bone is quite brittle. So we can make two cuts here, one cut. Good. So you know why we say tuck tuck, yeah? The first tuck is to get the thing in place, the second tuck is where you hit it. Yeah? That's what they teach in orthopedics. Yeah? Tuck tuck. So a lot of big size ENT guys are supposed to be orthopedic surgeons because you're big size, but unfortunately we get ENT surgeons. Yeah? Okay, so we go and remove the rest. Now, in real life, sometimes there may be a bit of bothersome bleeding from here. Use a cautery to cauterize it. Yeah? Here, So we will take this out. Sometimes we also keep this in order to use it to reconstruct the skull base. So here you are. So now you will see the sphenoid was still open, and this will never close up, yeah? Right? It will not close up. So, let me just pull away some, and you will see that there is mucosa here. When this mucosa comes out, you will bleed a bit, then it will stop, yeah? So here, you will peel the mucosa out. Doing a two-cut process. And you will remember this particular specimen on the CT scan showed that there was a septum. The central septum goes to this side, and the septum likes to arise. I think there's embryological reason to be close to either the carotid artery or the optic nerve. Yeah. Okay. So this is the central septum too, and we just take it so that we give good access for the neurosurgeon. We can also use views to do this when this is very hard. Then we can keep down by the side. If you want to bring it lower, then we will use a carison. So we can use a unbiting carison, but make it face downwards. Okay, then you can also use a carison to adjust it, right? You can take this with a carison like quite easily. So I won't do all of this. Then of course you know that the anterior wall of the sphenoid doesn't just stop here. It will go, if you were to look into the superior meanders, right? There's still someone that can take it. Yeah? You can take more of this to show. Yeah? And sometimes you also cut away the superior terminate. Yeah? It depends on what you want. So you can do all that. So if you were to cut away the superior terminate, watch out for bleeder. Now, because of what we teach now, we use 1 in 1,000 treatment. When we cut it, it doesn't bleed. But it will bleed about 8 o'clock when you're having dinner. Yeah? So whenever you kind of expose the mucosa here, the bone of course doesn't bleed. The mucosa can bleed later on. We take the cautery and cauterize it. Yeah? Cauterize it. If you take away the superior terminate, they must cauterize the bleed. Yeah? So that would be opening up the sphenoid very quickly. You can try on your own. The next thing is, we're talking about nasal septal flap. So this won't be a very complete nasal septal flap because the anterior window has been made. So I made a posterior window. So this is the pedicle, right? And of course we will go and extend it here. But this has been taken, it's fine. So let's just follow it. See, it's been taken, yeah? So this, we will just remove this. But so I would then go along here, follow this because it's a posterior window, then go up here, and take it from here. Yeah? But this has been cut, so I will just begin, we'll take it along here, from here, we come down. So it depends on how big you're going to take it. Nowadays, like Richard Harvey doesn't want to take such a big flap. If you take a big flap, the patient has a lot of plastic. So you use a blade to cut down here. Yeah. And okay, the pointers are, then we will go behind and we cut, you see the cautery, cut along here, right? Cut along here. And we keep the cautery there for a long time so that it will stop all the bleeding. Yeah? So we will take it down here, down here, down here. Now, the thing is, if you look at the nasal floor, if you want it to the flap to be broader, you can come up to the middle part. The middle part is where the blood supply ends. So if you go beyond the middle part, you can, that will be random blood supply. This one is the pedicle blood supply. So very quickly, on the cadaver, make a cut here, along here, along here. So give this a try, but your flap will be much smaller than usual because the anterior window has already been built. So the smaller flaps are easier because you can get the plane a lot easier when you are more posterior. Yeah. Good. So from here you can develop the flap and it will come up and then you can bring it into the nose. Do that in your specimen. So now I think I discussed with PJ yesterday and I think it's important that you understand all the structures in the sphenoid that you see. Most of the times you will not be opening it. Many of us who practice skull-base surgeons with our neurosurgeons, we only show those nice videos, but they're all done by the neurosurgeon, right? Because once the neuro is open, we are not accredited to go further. Yeah? Because although we think we can do it, what is important is, imagine that the patient goes back to the ICU and develops a hematoma in the brain. And we are not accredited, and I do not know how to evacuate a brain clot. So those who handle the complications do the surgery. So if there's a CSF leak, yes, I will do it. But if it's a brain clot, there's a bleeding into the tumor bed, you need a neurosurgeon, and many times they will open the head. You cannot do it from underneath the tumor. Yeah. So I'm going to pass over to PK. PK is an excellent anatomy professor, and he will charm you with all these